Hello, friends. Hope you are all now preparing very well for the fast approaching exams. Most of the colleges are having exams starting from next month. Nothing to worry. Just rely on the hard work that you have done last 3 years and probably the studies that you have been doing since last couple of months. Every question paper will have a question on drugs, whether it is in basic sciences or sometimes even in the recent advances or in obstetrics or in gynecology. Here is one drug which is useful both in obstetrics and gynecology. So this talk is not only for the exam preparation, but also it's a very, very useful drug for every single OBGYN practitioner. This is truly a boon for OBGYN. That's why I'm calling it so. Tranexamic acid, a boon to OBGYN. Let's learn in depth about this, not only to write a good answer in the exams, but also understand when to use, how much to use this particular drug. Because every good drug is having a chance of being abused or misused. So let us understand this clearly. What is tranexamic acid, TXA in short? It's a synthetic derivative of the amino acid lysine. So what does it do? It exerts its anti-fibrinolytic effect. So for any hemorrhage to stop, there has to be a fibrin clot, a stable one. If that clot is lysed, then the bleeding will continue. So tranexamic acid basically exerts its anti-fibrinolytic effect through the reversible blockade of lysine binding sites, because it's a synthetic derivative of amino acid lysine, that are there on the plasminogen molecules. So it will not allow plasminogen to lyse the fibrin clot. That's how it acts. So it is a very, very useful, at times life-saving drug also. And the beauty of this is it can be used in obstetrics as well as in gynecology, any time of pregnancy. Let's look in detail about the mechanism of action. In pharmacology, I used to find it very difficult to understand all these things, but now having gone through them, I find it is very interesting and very easy as well. So in the coagulation cascade, first there is thrombin, which is converted by fibrinogen into fibrin. And fibrin is very important ingredient of a clot. But plasminogen, which is converted into plasmin, will lyse this, and there will be fibrin degradation products. Tranexamic acid is a competitive inhibitor of plasminogen. So it will also at high concentration is a non-competitive inhibitor of plasmin, because of, as we just saw in the previous slide, the lysine binding sites on the plasminogen. Because it is a synthetic derivative of lysine, it will go and sit there, but it will not allow plasminogen to be converted into plasmin. And at higher concentration, it will not allow plasmin also to lyse the fibrin. So there is inhibition of both plasminogen activation and plasmin, leads to stabilization of pre-existing clot by impairing the process of fibrinolysis. There is no fibrinolysis, there will be a stable clot, so there won't be any fibrin degradation products. I think this is a very important slide, very easy as well. And if you just write this, you'll get full marks. Pharmacokinetics is also very important. It should be given intravenous, oral, or topical. We have seen all the three being used very commonly. This is an important issue for all the practitioners also to understand very clearly. It should not be given IM. Now, having said that, the disclaimer is except in tactical and combat situations. That means cases of convulsions have been reported. That's why it is better avoided. However, in combat situation means, suppose you are finding it difficult to get an IV line. She's bleeding like anything, and oral will take some more time and she is not able to consume it. Topical will, of course, not act so fast. In that confusion, in that tactical moment, in that combat situation, of course, you can give IM. The only fear is that of convulsions have been reported. Otherwise, the preferred route is IV, oral, and topical. Absorption not related with meals, so it can be given any time of the meal. Usual question many of the patients ask is, should it be taken before meals, after meals, during meals? Most of the drugs are usually better taken before meals, most of the drugs. But then, some people will have side effects, gastric side effects and things like that. That's why we usually tell them that they take it after the meals, but it is not related, so it can be taken anytime. The half-life is 2 hours. Metabolized and excreted by kidney. This is very important to understand. That is because most of the drugs that we say are metabolized in liver and excreted by kidney. But here it is both metabolized and excreted by kidney. That means it is admissible in patients with compromised liver, but not so with compromised kidneys. Effective therapeutic plasma concentration is 10 to 15 milligrams per ml for inhibiting fibrinolysis. So you have to achieve good concentration. Don't give half-hearted doses. When you have to combat the bleeding, give full dose. The first dose should be a good one. Peak of serum levels after IV is achieved within minutes. Within minutes. So you give IV. After IM, though it should not be given, in combat situations you may give. And oral route, maximum plasma concentration is obtained after 0.5 and 2 to 3 hours, respectively. That's exactly why it is preferred to give in IV when you want to immediately stop the bleeding. Once it is controlled, maybe you can switch over to orals. Bioavailability is 33% of oral drugs. So that's another reason why IV is preferred in emergencies. It crosses placenta, blood, brain barrier, and eye as well. Administration methods. In local fibrinolysis, suppose it's restricted to local bleeding, maybe sometimes even the nasal bleeding or any bleeding, it can be used for any bleeding because it has nothing to do with the subject specific. It's not that it's an obstetric drug. It's not that it is a ENT drug or any other drug. Any bleeding, as you saw, it actually helps in stabilizing the clot wherever it is. So if it is a local fibrinolysis, 0.5 grams, that is 1 ampule of 5 ml, to 1 gram, that is 1 ampule of 10 ml or 2 ampules of 5 ml, by slow IV. This is another common thing for any IV drug. You must give slowly. You should not give anything fast. 1 ml per minute, 2 to 3 times a day, you can give this. Whereas if there's a generalized fibrinolysis, then 1 gram, that is 1 ampule of 10 ml or 2 ampules of 5 ml, by slow IV, the same thing, 1 ml per minute, every 6 to 8 hours. So 2 to 3 times a day means 12 to 8 hours. But here it is 6 to 8 hours means 4 times a day, equivalent to 15 milligram per kg body weight. Hepatic impairment. No dose adjustment is required in patient with hepatic impairment. Why? You saw that it is both metabolized and excreted through kidneys. So that's what I said that time, and again I'm repeating. There is no need to adjust the dosage even if the patient has got hepatic impairment, and that's a boon for us in obstetrics, because most of our obstetric confounding factors are comorbidities. For example, preeclampsia or any other problems will have some effect on the liver, or cholestasis of the pregnancy, fulminant hepatitis. All these situations, tranexamic acid is welcome. It can be given. That's the advantage. Whereas you have to be a little bit careful if there is renal impairment. It is contraindicated actually. In patients with severe renal impairment, due to risk of accumulation. That's all. So some amount of impairment that can happen in preeclampsia in the renal system is okay, but if there is a total renal impairment, then it should be withheld. Reduced in patients with mild to moderate renal impairment according to the serum creatinine level. So that's what I just said. If there is a mild or moderate impairment, it is not contraindicated, but you can adjust the dosage depending upon the creatinine level. But if there is any hepatic impairment, there is no need of dose adjustment at all. What are the indications? The title said it. Indication is obstetrics and gynecology. That means hemorrhage, any hemorrhage, whether it is excessive flow during normal menstrual cycle, to AUB, to bleeding due to cancers in gynecology, in obstetrics, first trimester bleeding, second trimester bleeding, antepartum hemorrhage, postpartum hemorrhage, anything and everything. So any obstetric and gynecological bleeding. I have this bad habit of repeating things when it is very, very important and I want to impress upon. Any obstetrics and gynecological bleeding. PBH, I want to start from there because it is life-saving. Other day I took a class on uterotonics. Yes, but there I remember telling you can also give tranexamic acid as the uterotonics are doing their job. 1 gram IV within 3 hours of delivery. Within 3 hours of delivery. But nowadays, I'll talk about the studies that have been done. But here you have to give 1 gram IV within 3 hours of delivery. When you give that, it's definitely going to help. High dose infused over 7 hours, 4 gram IV stat, then 1 gram per hour into 6 hours, significantly reduced blood loss. Limited evidence for prophylactic use. That's the thing. Those are the studies. They are now trying to give it as a prophylaxis. Uterotonics, no doubt, oxytocin, carbitocin, or even fixed dosage of oxytocin and symptometrin, even ergometrin can be given for prophylaxis against PPH. But there is limited evidence of using tranexamic acid for prophylaxis. But if there is bleeding, then you can definitely give. Other obstetric hemorrhage, it is used in abortion, antepartum hemorrhage due to placenta previa, including accreta, increta, percreta, even if it is abruption. Of course, in abruption, we know that the problem is different, delivery is the answer, but if there is bleeding, you can use this. Whereas for threatened abortions, antepartum hemorrhage due to any of the placental other conditions, you can give this to stop the bleeding. Heavy menstrual bleeding, that is in gynecology, 4 to 4.5 grams per day. Many mothers, many young girls are scared to take even one tablet. I don't know whether it is because of the cost of the tablet or whether they are somehow worried thinking that this drug is very, going to be dangerous to them, things like that. You see 4 to 4.5 grams per day. After all, what we are usually giving is 500 milligrams 3 times a day, which is hardly 1.5 grams. So that itself, many people take half a tablet. Sometimes they take 1 tablet and they just manage with themselves. Please, we have to sit and explain to them. Nothing will happen. 4 to 4.5 grams per day for up to 5 days per cycle was shown to reduce menstrual blood loss from baseline levels. So we ourselves first should be convinced, and then only we can convince our patients. In gynae surgeries, tranexamic acid reduces blood loss in variety of gynae surgeries, starting from TAH, myomectomy, ectopic, cervical conization, ovarian cancer, hysteroscopic surgeries. Anywhere there is bleeding, you can give tranexamic acid. Trauma, of course, I don't have to again stress that. Yes, I kept on saying you can give here, you can give there, you can do this, you can do it, it's a boon and everything, but are there any contraindications? Yes, any drug that has got hypersensitivity, you have to be careful. So also hypersensitivity to tranexamic acid and other drugs. After all, it's a protein, right? It's a synthetic derivative of lysine. So any protein that will have some hypersensitivity, especially when it is given in IV or IM. So there will be vehicle that is along with that. It could be due to hypersensitivity of the drug, or it could be due to the vehicle that is used to give the drug. Active thromboembolic disease or pulmonary embolism. Suppose a person has the problem of coagulation or embolism. Then, of course, because this is the one which is going to create clots, isn't it? It is going to stabilize the clot. There, of course, DVT, it is contraindicated. So we have to tread a balance, or we have to tread carefully in such situations. History of DVT or arterial thrombosis. In these patients, we have to be very careful. Now, suppose the patient has postpartum hemorrhage, you have used it to stop it, but then later in the postnatal period, if she develops DVT, then you have to be a little careful while using this, because this is going to create thrombus. It is going to create clots. So that is very, very commonsensical understanding where it should be contraindicated. Fibrinolytic conditions following consumptive coagulopathy. This is a very, very different and difficult situation where there is consumptive coagulopathy, and the situation has to be very carefully treated. Renal impairment, I have already told you, both metabolization and excretion happens through the kidneys. So if there's a renal impairment, it should be withheld. However, mild renal impairment, dose adjustment can be done. Epilepsy, it has to be carefully, monitored and given. Not recommended with desogestrel. Somehow with hormones, it is not recommended. And Dynogest, medroxyprogesterone, norethindrone, norgestrel, drospirenone, estradiol. You can make out now why. Because these, especially any hormonal, steroidal hormones, especially estradiol in that, it will cause thromboembolism, isn't it? It will cause clots. And here is a drug which promotes clots. So that is exactly why, probably, even we thought only estrogen causes clots, but it's not true. Even progesterone causes microthrombi. And that sometimes is the reason that suddenly there can be blackouts. You must have heard this. I mean, it's slightly dangerous for me to tell here that if very young girls use long time oral contraceptive pills, there can be microthrombi because of the progesterone. And that also we have to be very careful. So generally, it is not recommended. Generally, it is not recommended with these hormones. But however, other day when I was talking about this in another conference or webinar, they asked me a question. In a case where there is heavy menstrual bleeding, you are giving tranexamic acid and also you are giving progesterone. So how do we do that? Yes, of course. As you know, tranexamic acid is something like a first aid or first drug, first line drug. The hormones will act sometime later. So once you control the heavy bleeding with this, and by the time you start, usually we start progesterones from day 5 to day 25, isn't it? So that is where first 5 days you give this and control the bleeding. And once you start the progesterone, so you stop that. Suppose you are giving progesterones as to arrest the hemorrhage, like for example, norethindrone acetate. If you start from day 1, there also, of course, luckily these hormones, progesterones, norethindrone, they will start acting after 24 to 48 hours. So once you think that the progesterone is taking over, you may sort of taper this. I hope I'm clear. So initially use tranexamic acid to control the bleeding because hormones will take some time to start acting. But once the hormones start acting, you withdraw the tranexamic acid. And when you are giving maintenance dose, it is usually from day 5 to day 25. So there is absolutely no problem. How about tranexamic acid plus mefenamic acid? This is the most favorite combination, and there are lots of companies coming out with this. Can it be given or not? That is antifibrinolytic is on one hand, other one is NSAID, which blocks production of prostaglandins. So prostacyclin especially, they will lyse sometimes. So mefenamic acid will block that. It helps relieve menstrual pain, that is mefenamic acid, which is antiprostaglandin, and abnormally heavy menstrual bleeding. So it's a good combination. It can be used. To be taken on first day of heavy menstrual bleeding, taking it before or after will not have any benefit. So that is why many, again, mothers and ladies will ask us, should I start before the menstruation starts as a prophylaxis? Something like they think that we take sometimes malaria prophylaxis, some people simply take paracetamol in the anticipation of fever and things like that. That is not actually correct. You need not do that. Similarly here, in the anticipation of menstruation, you don't have to take. Similarly, after the heavy menstruation starts, if you take, it may not act well. Both are wrong. So you start when the menstruation starts, day 1, okay, of heavy menstrual bleeding. Then, of course, you can taper it, and then you are starting the hormone if you start hormones. If you're not starting hormones, you can continue this for another 2-3 days, couple of days. What are the side effects? Pale skin, unusual bleeding or bruising. So sometimes, opposite can also happen. Unusual tiredness or weakness, trouble breathing with exertion. So these are maybe some of the effects of the clot that is formed. Nausea, diarrhea, the usual problems of any drug, itching, and heartburn, headache, dizziness. So that dizziness is basically because of sometimes mefenamic acid. What is the clinical evidence of whatever I spoke so far? Without evidence, it is not correct to speak. Heavy menstrual bleeding. Calendar et al. Did this study, and it was published long back, 1970s, as you can see. Women received either 500 milligrams of tranexamic acid 4 times daily for the first 4 days of their menstrual cycle, or placebo for 3 menstrual cycles. TXA use resulted in significant reduction in pad count. So it was proved not now, maybe 50 years ago. And till today, there is no dispute about that. Remember, they gave 4 times a day. Nothing happened, 2 grams. In fact, I told you 4 to 4.5 grams can be given. No, I am harping on this. I am just stressing on this because I have seen people are so scared to take 2 times a day, 3 times a day. Nothing will happen. You have to take. It is better than having bleeding. Lukes et al. Randomized women with heavy menstrual bleeding either into Trenexa 1.3 grams 3 times a day. That's also 1.3, 3 times a day is almost 3 grams, 4 grams per day for 5 days during menstruation and matching placebo. TXA use had 40% reduction in menstrual blood loss compared with an 8% reduction in placebo. That is surprising. Even placebo is reducing the blood loss. When compared with oral progestin therapy, TXA was found to be more effective in reducing menstrual blood loss. Yes, this will stop the blood. See, many people think that progesterone will stop the blood. Progesterone will not stop the blood in that way. It has to work indirectly. It will make the endometrium sort of secretory type of endometrium, and it will stop the proliferation of the endometrium. So that's how probably indirectly it helps. But tranexamic acid directly helps. Prevention of PPH, meta-analysis of 9 RCTs consisting of 2,365 women. And this is a recent publication, almost 2016. Prophylactic tranexamic acid administration, this is talking about prophylaxis now, is associated with significant decrease in postpartum blood loss. Mean difference of 160 ml. A significantly lower incidence of PPH and severe PPH. A significantly lower hemoglobin drop. Significantly less need for additional uterotonic agents. So uterotonic agents will be like a complementary, but there was no need of additional uterotonic agents. Suggested consideration for adding tranexamic acid as 1 gram or 10 milligram per kg IV, 10 to 20 minutes before skin incision or spinal anesthesia. So this has become a habit for most of us now that before we incise, we give this. And it will not come in the way of our cesarean. It will not come in the way of anything. Of course, we have to be careful in a patient who is more likely to have clots and DVT and things like that. Otherwise, a normal patient, you can give this. This is the most famous trial, that is woman trial, to understand the effect of early tranexamic acid administration on mortality, hysterectomy, and other morbidities in women with postpartum hemorrhage, that is woman study in international randomized double-blind placebo-controlled trial. Dr. Arul Kumaran has, in one of the conferences, really spoken so well about this, and I was really impressed. It was long back. It's not the recent one. It's 2017 Lancet article. So this trial is the one which really opened our eyes and said that, yes, tranexamic acid should be one of the important drugs in your cart in the labor room. It has to be used very, very effectively. It can be used. Study population consists of 20,060 women aged 16 years and older with clinical diagnosis of postpartum hemorrhage after vaginal birth or cesarean section, both, from 193 hospitals in 21 countries. What more you want? Objective. I mean, other day, some PGs are asking me to give a talk on landmark trial. This can be considered as one of the landmark trials. Write all these numbers. It is very impressive to the examiner. The objective was to evaluate effects of early administration of tranexamic acid on death, hysterectomy, and other relevant outcomes in women with postpartum hemorrhage. Intervention was 1 gram IV tranexamic acid or matching placebo, in addition to usual care. See, in addition to usual care has to be there. Otherwise, you won't get ethical clearance. That only you give one group this, one other one, nothing else is not acceptable. If bleeding continued after 30 minutes or stopped and restarted within 24 hours of the first dose, a second dose of 1 gram tranexamic or placebo could be given. So it was not just one dosage. If there was a continuation of bleeding after 30 minutes of giving this, you can repeat it, or if it restarts within 24 hours, you can repeat it. So what are the results? Death due to bleeding was significantly reduced in women given tranexamic acid. As you can see here, 0.81 relative risk overall. Women given treatment within 3 hours of giving birth, death due to bleeding decreased by 31% in the tranexamic acid group. 31% is a really, really good achievement. Interpretation was like this: the administration of tranexamic acid to women with postpartum hemorrhage reduces deaths due to bleeding with no evidence of any adverse effect or complication. What more you want? That's all we want, right? WHO recommendations, January 2018, strongly recommends, WHO strongly recommends early use of IV tranexamic acid within 3 hours of birth. Earlier the better. In addition to standard care of women with clinically diagnosed PPH following vaginal birth or cesarean section. A fixed dose of 1 gram, that is 100 mg per ml, IV at 1 ml per minute, that is given over 10 minutes, with a second dose of 1 gram IV if bleeding continues after 30 minutes, or if bleeding restarts within 24 hours of completing the first dose. It is based on the same finding of that particular study, which was published in Lancet. ACOG also recommends tranexamic acid, which prevents blood clots from breaking down, can be administered when initial therapies fail, and has been shown to reduce mortality when given within 3 hours of birth. Thank you very much for your patient listening. I hope it was useful to you. You can definitely score a good marks in this question on tranexamic acid. Otherwise, also you can successfully save a mother's life or relieve the heavy menstrual bleeding of a teenager. Thank you very much.